Hello, everyone. Welcome to Perfecting PT. This week, I am Dr. Nate Nor, Doctor of Physical Therapy, and I am joined by Ryan Lynch. He's a physical therapist out of New York, I believe. Where are you out of, Ryan?
Maryland.
Maryland. So we have Ryan out of Maryland. He owns his own private practice, Lynch Physical Therapy, and he is specially certified to treat TMD issues or TMJ issues, sorry, as well as other oral facial pain. Is that what you would call it, Ryan?
Yeah, absolutely. So one of the first things to kind of just jump right into it, one of the first things that we see with patients is they'll come in and say, I've had TMJ. And my initial thing is, well, what does that mean to you, right? Because TMJ can be jaw clicking, jaw popping, difficulty eating, locking, open, closed, localized pain here, pain in the trigeminal nerve region, oral facial pain, headache, all that stuff. So that's my first question is, what does that mean to you? Because TMD or TMJ pain, as they're going to call it, is this big umbrella that all these things fall under.
Sure. It's kind of like when patients come in and they're like, I got sciatica. And you're like, oh dear. You're like, what does that mean?
Yeah.
Okay. So first off, I just want to be clear for anyone listening, people there is credentialing and special courses to be at a higher level of treatment quality for these conditions of the face, the mouth, the jaw. What is that credentialing called?
So the main credentialing is certified cervical temporomandibular therapist, which is in my credentials there, which is the CCTT of it. Without getting into a huge backstory of it, it is not one of the 9 recognized specialties through the APTA. They did some. They originally tried to get it through there, but it didn't really work as well. So we are credentialed through a sister academy of the American Academy of Oral Facial Pain. So that's kind of our sister academy. That's where we do our conferences, and that's where our credentialing comes through.
Okay, and so if anyone were interested in pursuing that same credentialing, would they just go through that American Academy of, you said, oral facial pain?
Oral facial pain. So actually, they can go to the website, which is kind of unusually labeled as ptbcct.org, and that will give you the list of what you need to do to qualify for it. So it does require a certain amount of education, and then it doesn't matter, then an exam, and then it does require a certain amount of continuing education that you recertify every 2 years, just like you would your physical therapy license.
Okay.
So it does require some sort of commitment in order to kind of show that you've done the work, show that you're still participating in it. Much like some of the ortho specialties, you have to be treating oral facial pain for X amount of hours prior to do it, just so that, it's somebody who has experience to do it.
Okay, awesome. Okay, that's good to know. And so is it essentially just a series of continuing education courses followed by a test to become credentialed along with the hours of treatment?
Yeah, so that's a good question. The problem is there's not a real distinct course of how to do it. You take A, then you take B. If you go to St. Augustine and stuff, it's like, oh, you do ABC and you go through the process this way.
Sure.
Most people's paths are very different. So I ended up taking a course of somebody who taught it specifically. I asked him who taught him. I took that gentleman's course. I took Mariano Raccabato's course, who's kind of the most famous physical therapist who teaches oral facial pain. He comes to the United States, I think, about once or twice a year now, so it's very limited. Oral facial dry needling, that just was the course that I took to get there. But there's not a specific route. It's basically if you find an interest and you see that you're treating these people, and that's your passion, then we kind of can guide you to, hey, let's maybe take this course. If you're short on knowledge or don't feel real confident in this area, let's look through here. And that's even just people who are other CCTs teach it. I teach a course as well. But it's also, there's EMI people, there's ICE people that you can kind of cherry pick out really good courses that are taught across the country with the specialization of basically cervical spine and superior.
Okay, awesome. So if anyone were interested, maybe after listening to this podcast, to attend the course you teach, what course is that?
So I teach a course. It's called Managing TMJ Disorders with Physical Therapy. If you're interested, it is at LPT Seminars. So for Lynch Physical Therapy, but short, lptseminars.com. We do it primarily in where a group would say, "Hey, come into our organization and teach for it," versus me saying, "Hey, I'm going to be at the Hilton this way." It's just easier to have all the setups, but definitely. And then you can reach out. I'm available for any sort of correspondence. In all honesty, we're such a small group, and we would love to expand and get this out to the public that, hey, PT is a real good option for oral facial pain. So please reach out to me personally if you have the interest, because I will personally respond and kind of give you any insight or any path that would help you along the way.
Okay, great. Thank you. And
Yeah,
for anyone
absolutely.
listening, everything we talk about, all the websites, the names, any books, any courses, I will include those in the show notes. So don't feel like you got to keep recording, like rewind and be like, "Oh, what'd he say? What'd he say?" Everything will be in the show notes to reach out to Ryan or know what the heck we're talking about.
Yeah.
So going back to what you were saying, Ryan, people come in and they're like, "I have TMJ or TM." Everyone just says TMJ, even though it's TMD.
Yeah.
They're like, "I have
Yeah.
TMJ," and it sounds like there's a lot of things that could be TMJ.
Correct.
So why don't you tell me a little bit more about that? So when someone comes in and they say that, what things are they saying that you're actually like, yes, they do actually have a TMJ dysfunction?
Well, so I don't necessarily decipher whether or not it's TMJ, to use the literal meaning of it, whether it's the joint itself, because a lot of
Okay.
patients will come in and they'll have, "Hey, I can chew, I can open my mouth real wide. My ENT sent me here because I had what I thought was an ear infection. He or she told me I don't, but he says the pain is coming from my jaw. I don't get it. My jaw opens fine, and that's where we bridge the gap." So I don't necessarily say, "Hey, this is a problem with this joint. It's a problem with this kind of region." It's really almost kind of is in that whole upper quarter, or sometimes it's both, both sides, that
Sure.
it can be an issue with. So really, the two biggest referral sources for our clinics are either dentists or ENTs. So we get a lot of, "I feel like I have a cavity. My dentist told me I don't. He told me to go to physical therapy." Or, "I feel like I have an ear infection. I don't. My ENT told me I don't, but he told me to come to physical therapy." So that's, of course, that's the how a lot of patients end up in our offices.
So it sounds like it doesn't even have to be popping, clicking, snapping. It's just kind of general, like
Correct.
facial jaw, mouth pain.
Correct. And, the old adage in physical therapy is no pain, no patient. And it doesn't necessarily have to, right? It doesn't necessarily have to be, though. It can be just discomfort. What we do see, to bring up your point about clicking and popping, is, patients will come in and say, "My jaw's clicking and it's popping. It doesn't really bother me, but I'm concerned this is going to lead to something. Am I breaking down the joint? Am I setting myself up for problems down the road?" So that's
Sure.
something we address as well. So yes, for most physical therapy, pain is the driving force, but not always.
Sure.
Ear,
So
I'm sorry to interrupt. Ear fullness is a good example. So we'll get a lot of
oh,
patients who say, "Gosh, my ear feels full. I don't. It feels like I got off a plane and it just wouldn't pop." So that's not necessarily pain, or of course dizziness, stuff like that. But this is concerning. I can't hear, that type of stuff. So that will drive patients into the office as well.
okay. So I guess that leads to my next question. If anyone's listening may have the same one. Is popping and clicking in the jaw a pain, like an issue? And if it is happening regularly, can we really say if that's going to lead to a degeneration and worsening issues in the future?
So the answer to that question is probably going to depend on who you ask. I
Sure.
personally, and I've based my treatment philosophy on the literature. The American Academy of Oral Facial Pain is a scientific community, so all of our treatments, all of our kind of education is based directly off research in the literature. So that's where
Sure.
I base it. Very simply put, your jaw functions that the mandibular condyle sits in the temporal fossa this way, and you have a
Hmm.
disc, which is cushioning, meniscus, cartilage, And it basically, instead of the two surfaces being both covered in cartilage, you have a disc, and that disc moves with the condyle as the mouth opens and closes. The disc or the jaw clicking is basically a pulled forward anterior displacement. And now you basically have an obstacle on that course. So your jaw is going to go popping over it. The good thing about that, well, that's annoying. It's not really a medical condition. I always relate it to the other physical therapists. It would be like going into an orthopedic surgeon's office and say, my knee, can you hear this? Click, 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 click. I get up, I run 2 miles every morning. I kneel on it all for an hour on Sundays at church. It doesn't hurt. It just clicks. Is that a problem? Most orthopedic surgeons are going to say, have a nice day. You're fine. Same idea with the jaw. While it's annoying, it's not really a medical issue, because what will happen is the retrodiscal tissue, which is the posterior, which is the tissue that attaches to the posterior aspect of the disc. After you hit that enough, it's innervated and vascular, so it will hurt. But after you hit it enough, it'll callus, it'll scar, and you will not get that pain. You'll still get the click, but we've formed kind of a pseudo disc. So you're not really at a medical disadvantage with that. So to answer your very short question with a very long answer, it's not, one of the things, and we'll probably touch on this throughout the course of our conversation today, is that education is a big component for oral facial pain. Patients want to know, hey, is this a problem? And to speak to that, if they're not having symptoms, I typically explain what's going on. Patients are super relieved. They'll say, how come nobody's told me why my jaw has clicked in the past 30 years? They give me a high five and they go on their way. They develop pain down the road, they come back. But not necessarily that they'll develop pain.
Sure. So it would seem that the big driver, even though everyone would say, oh, I have TMJ issues, I pop, I click all the time, it would seem the bigger driver for it needing to be managed through physical therapy is some type of annoyance beyond popping, clicking, some type of ear fullness, pain around the jaw, difficulty opening, difficulty chewing. And what about catching?
So you will see that, but what typically will happen is that's kind of a form of locking. So back to my model here, and I apologize because I'm blocking my mouth while I do it. But if this disc is now slipped forward, you can kind of sometimes pop over it and then have difficulty backing up over it, or you can't pop over it, and that's really how your jaw locks. So you'll see people with an unusual opening pattern that they'll kind of go around it. I equate it to being in an empty parking lot at night and there's a speed bump. Well, what do? We drive around it to make it a softer turn. That's what your jaw is doing as well. Instead of forcing over that obstacle, you're coming around it. And that's where you'll see an unusual ataxic jaw pattern.
Oh, interesting. So they never told us that in school. So those deviations of the jaw are essentially it trying to create the easiest path to get back to normal without either catching or locking on that disc.
Correct. And you honed on a good word there, because the actual term is deviation. And the other thing would be deflection. So deflection, it would be when you open and then go to one side. So if I open and go towards my right and end up on my right, that's deflection. And as PTs, we typically know, look, something's in pain. This side muscles are tight. When we open, it's going to go towards the side of tight muscles. So that's another thing too. But those are kind of the things that you hone in on. Hey, I noticed my jaws kind of goes goofy this way. Yeah, you're trying to get around the disc. Or, hey, my jaw's coming and always ends up to the right. Okay, I bet your problem's on the right and those muscles are tight. So real quick and dirty kind of things you can assess right off the quick assessment that gets you right in the ballpark of what you're looking for.
Sure. So a deviation would be, maybe it's kind of an S, maybe it's just a big curve, but it still ends up in the middle. A deflection is as you get fully open, you end up on the left or right, and the side that you end up on is the side that is having some type of muscle tightness or restriction.
That you're 100% correct. The deflection changes a little bit with people that open super wide, but for 95% of the cases, exactly what you said is going to be spot on.
Perfect. So let's say a patient comes in and they're complaining of this like oral facial pain. I know that as part of your credentialing, it is the neck as well. So how are you deciding? Can you decide based off what they tell you in the interview, whether you're looking more at the face and jaw versus the maybe upper cervical spine or just cervical spine in general?
Sure. So what I said earlier was that the majority of our patients are referred from either a dentist or an ENT, and then probably friends or people that we've treated. But
Got it.
really, what the limitation with that is that, and again, not to offend any of my dentists or my ENTs, but in general, the scope is your dentists are going to look: are your teeth straight? Do you have cavities? Your
Sure.
ENTs are going to look at ear, nose, throat. It's in the initialism of their name. So what we find is, as oral facial physical therapists, are the two components that are often overlooked, which are significant components to their dysfunction, is the cervical spine. The literature is going to tell us that the cervical spine is connected to oral facial pain in about 70% of cases. That's what the
Hmm.
strict literature says. My
Okay.
office, I can say that that's probably 85%, excuse me, that patients
Okay.
come in and say, yeah, my jaw hurts. It hurts right here. Anything else? Ryan, my jaw hurts right here. Oh, how about your neck? Oh, yeah, my neck hurts, but it always hurts. Or you touch their neck and they go, oh my gosh, I had no idea how tender that was, especially in the
Sure.
suboccipitals, because people aren't really being touched there. So that's
Sure.
the first thing. So there's a huge connection with the cervical spine. Travell and Simons, showed us that with their referred pain patterns, and leads me to the next one, which is muscles. Muscles
Sure.
produce pain, and that circles back to what we first started to with the actual TMJ. That
Hmm.
it might not be the actual joint, but it's the muscles. The masseter is going to refer to the teeth. These muscles are going to produce this pain that is going to be really the root cause of the patient's symptoms, especially when they've already been ruled out by a dentist, ruled out by an ENT. We can say with a good amount of certainty, hey, this is what it looks like to me, because we know that these other structural deficits have been ruled out.
Sure. So there are a lot of muscles in the body, but I find that not all of them cause problems equally. Do you find that around the jaw, like I know when I did my dry needling course through St. Augustine,
Mm-hmm.
and they taught us masseter, they taught us pterygoids, they taught us temporalis. Are you
Yep.
finding that one of those or a pair of those are commonly the issue, either on the same side or the opposite side of their issues?
Sure. So the real easy one is masseter. Masseter is going to
Okay.
be, people are going to have pain. So even if that's not the cause, because of the role of masseter and it being the main jaw closer, that's where we're going to see a lot of even dysfunction, even if it's secondary or tertiary. The pterygoids are another good one. A little bit harder to tease out because when you palpate the pterygoids intraorally, they're typically tender on most people because it's not a spot that gets touched a lot. But I do
Sure.
find that's very helpful. Really, the interesting thing about the pterygoids, lateral pterygoids specifically, is that your right lateral pterygoid causes excursion or deviation to the opposite side. So if you're
Okay.
resisting motion, so patient's got pain on the right side, I can move my jaw fine to the right, but gosh, when I move it to the left, it really hurts. There, you've really been able to hone in. Man, that's probably a pterygoid issue. And I do like you needling the pterygoid because it allows you access to a muscle that you don't really get great access to palpation wise. So we do
Sure.
that a lot. But yeah, masseter and the pterygoids are really the good ones. Medial pterygoid for ear fullness. Medial pterygoid, that muscle sits next to tensor valley palatini. Tensor valley palatini dilates the eustachian tube. So if medial
Okay.
pterygoid is engaged, which is most of our patients, because most of our patients are clenchers or grinders, meaning that
Okay.
the three main jaw closers, temporalis, masseter, medial pterygoid, are engaged, that's going to impede the work of tensor valley palatini, give that ear fullness. So I'll go after
Hmm.
that for ear symptoms. And then SCM. SCM is a muscle that, when I was a quote unquote more traditional physical therapist, I don't know that I touched it on many people. I touch it on every single oral facial pain patient. The referred pain patterns to the ear, apex of the head, you can really tease some stuff out there. So I will typically do, to kind of summarize, I will look for upper trap, suboccipitals, SEM, masseter, and the pterygoids are my go-to. Temporalis I'll do if they're having morning headache, something like that. That's a good sign. But yeah, those are the big home run muscles for oral facial dry needling.
Okay. And when you are testing them, do they need to be tender, or are you ever going just off, your palpation skills of saying this feels different than the other side?
So probably a little bit of both. So if somebody comes in and they say they have ear fullness, and we take obviously a pretty detailed subjective first, I kind of know that I'm gonna be honing in on medial pterygoid, SCM, masseter, the deep head of masseter, because those are the ones that are going to refer to the ear, pterygoids as well to a degree. So I do kind of go in knowing that. Ear fullness, though, because we think it's the one muscle impeding another one, it's not necessarily as cut and dry as like a gastroc strain. Oh yeah, I can palpate the trigger point in gastroc. We know where we're going after it. We're going to hit this. I always equate it to, it's kind of like, hey, I'm doing this to knock over one domino to knock over another one. So that's where I'm going to go to. But I believe so that's for kind of where I'm going to go off the subjective from a palpation standpoint. Yeah, just like we would dry needle anything. This is what's tender. This is where we think has to happen. But I am honed in from, the subjective of what muscles I'm suspecting are going to be problematic.
Sure. So it seems, so recap for anyone listening, because we're going about 100 miles an hour. I can't wait to listen to this back and take notes. So it seems like the big things that you are addressing, the big complaints, are ear fullness, either referred pain into the teeth, referred pain kind of at the jaw, difficulty opening or closing their mouth. You alluded to morning headaches.
Yep.
What am I missing? Any of like the big things that people are coming in for that are really the hallmark things?
So what, and I'll just, because yes, I did go breeze through those pretty quick to kind of briefly summarize. And again, please reach out to me if you have any questions. I would love to even just be a resource. That's what, in the oral facial community, we're a small group. So we really depend on, hey, I got this case. Have anybody seen anything like this? What have you done with success? So please don't hesitate from that. So I guess the first thing we can just touch on is, or to summarize is, jaw clicking and popping. Is it painful? My first thing is, let's educate you why, like we spoke about earlier. Your disc is typically displaced. This is what's going on here. Here's how you can reduce it. And it depends on where the patient is in the stage. Is it acute? Is it chronic? This is how we can address that. And then from a referred pain pattern, okay, I have pain into my teeth. All right, we think that that's probably going to be masseter or temporalis. Those are the two that Travell and Simons told us that will refer to the teeth. Anterior digastric will refer just to the bottom teeth here. Masseter and temporalis are going to be your biggest ones there. That's what we'll see. From an ear perspective, the three symptoms we typically see are pain, ear fullness, and then ringing. Ear pain, once been ruled out by an ENT, is almost a home run for PTs. That's almost always referred pain from an oral facial muscle. We'll knock that out. You'll have a patient for life who will be singing your praises from the rooftops. Ear fullness, as we described before, typically SCM, medial pterygoid, that type of stuff. I'll go in. I will probably for that go to dry needling a little bit quicker than I would with other things, only just for access. You can't get those muscles real well. And then ear ringing or tinnitus, I will level with the patient right off the bat. We don't know the cause of that. I know that as a physical therapist, I can work on these structures and I can manipulate ear symptoms. Ear ringing is not necessarily one of them, but I've had success with it, but it's really going to be one of those 50-50 ones. I will tell you though, those patients that come in with ear ringing have been through everybody. They've done every little trick on the internet they've ever found. When they see a PT who's like, this is what we're going to do, we're going to do this in treatment together, they'll say, you know what, Nate, I'm in with you. Let's try it. We'll do this together. They're in it. So that's it's an easier sell for those patients than you would think.
Okay. So my follow-up question is, how often is cervical spine causing oral facial pain? Because you said that it's often happening at the same time, but
Yeah.
is it often that like oral facial pain is precipitated by neck pain, or like I had neck pain for a few weeks and then I started getting facial pain? Or is it ever the other way around where they're like, I was having some jaw pain, my clickings got worse, and now I'm getting neck pain or headaches?
So what I'll typically tell patients or when we teach is like, it's very almost chicken or egg. And that's really,
Okay.
it's, if you read medical literature, it's written a lot fancier than that, but that's basically what they're saying. And it'll say, does jaw clenching cause neck tightness, or does neck tightness cause jaw clenching? Regardless, we have to address them both simultaneously, as you just said. I would say disproportionately, unofficially, I'll say 75% is primarily muscles of mastication with servogenical issues as secondary. And we do have some the opposite way, but as if you had to guess, I would say about 75%, excuse me, are resulting from orofacial muscles. But we still address them both. I mean, we always say, hey, if I get the tightness in your jaw under control, but you have this chronic neck tightness, after a while, it's going to creep back up. So we address them simultaneously, shift our focus and our time in the office to what we think is the bigger problem. But I would say 95% of my patients, I address some sort of cervical dysfunction in addition to orofacial.
Sure. And that makes sense to me that you would address both, but obviously they're not in the clinic for very long. We're looking at max an hour for most patients, depending on the clinic's model. It's like you have to address what you think will make the biggest changes.
Correct.
So I think the people listening will be very appreciative, especially in the detail you went to where you're going based on what they tell you. So let's say, when you assess a patient that's coming in for oral facial pain or neck pain, or both, do you have this kind of standard process where you're like, hey, I want you to sit down, I want you to look like right rotation, left rotation, like you go through cervical stuff, you do jaw stuff? Like, could you kind of delineate how you go about assessing a patient who would come in? And if it would make it easier for you, you're welcome to pick one of the categories you told me. And if that helps organize your thoughts.
Well, so the start for us is the subjective. And I used to ask all the questions, but our EMR system is very adaptable. So we send it out to the patient beforehand. So we do the basic stuff, past medical history, past dental history. And I don't necessarily care what you had done. How have you tolerated dental procedures? Can you keep your mouth open for a prolonged period?
Sure.
And then we go through the kind of the basic stuff, but we have a lot of questions because I'm trying to get a sense of what all the irritants, because for oral facial pain, it's not typically one irritant. It's a culmination of a bunch. So in our intake, we ask, what position do you sleep in? How long do you sleep in a night? Is it quality sleep? Do you drink enough water? What is your quality of food that you eat? What is your workstation setup? What is your job? Are you sitting for a prolonged period? Are you moving around? What do you do recreationally? Are you active as a floor nurse, but then go home and are a gamer for 4 hours? What's your computer setup look like? We talked about sleep, but what position do you sleep in bed? How are you doing childcare? So we're trying to get a good snapshot of how these people are functioning. Are you having difficulty eating? Are you having difficulty eating chewy foods, crunchy foods? Opening your mouth wide to take a large bite? Can you yawn without discomfort? So we're trying to get a snapshot of all of these irritants. So that's when I sit down with a patient, they've already filled that out on the form, on the online form through the portal. So I have a decent set of what's going on from then. So then I typically will say, well, tell me about your history. What happened to you? I don't need the whole history, but
sure.
Give me the highlight or low light reel, depending on how you look at it. When did you first notice these symptoms? Have you required therapy? And you'll be surprised that most patients will give you a pretty good, like, oh, I had this, I got an appliance, in my teens, and they'll give you a pretty good snapshot of what's going on and then how it became to culminate in the last, months or whatever that drove them into therapy. So that's the subjective portion. And then from an assessment portion,
So
Exactly. We'll do a
can I
standard.
pause you for a second?
Yeah, absolutely.
So you said a lot of things there in the subjective portion, and
Mhm.
so what responses are they going to say that you feel give you the most information? Because you listed off sleep, chewing, yawning,
Yep.
activities, work.
Yep.
Do they use computers? Like, what
Yeah.
things are they saying about their sleep, about their work, about their eating that actually gives you information? Because I know it all does. Like, and I think
Yeah, for
that's the
sure.
hard part about this because it's a complex issue.
Yeah,
But
absolutely.
like,
So we'll
sorry, like if someone sits down in front of me and they're like, well, I sleep 4 hours a night, I'm having a hard time eating. Like, what do I actually get from the things that they're telling you in those questions is really what I'm getting at.
So we'll talk about eating, for example. So eating
Okay.
is okay. You know what? I can't open my mouth for large bites. That's the one you're going to hear in the office a lot. I have to
Okay.
smash my sandwiches down. I sometimes when I eat it, I can't eat a salad because when I jab the lettuce with the fork, it makes it too wide. I can't open my mouth that wide. So just
Sure.
off something like that, we're like, okay, masseter. Masseter is going to be our main culprit. Masseter is the main jaw closer. Masseter doesn't want to stretch to open. That's what I'm
Mhm.
looking for there. So, all right, now I'm thinking this is what's driving that patient into the office. Let's talk about I wake up with a temporal headache. So, temporal headache, or temporalis, one of the three muscles that closes your mouth. So
Sure.
we know that that's going to be typically someone who's clenching overnight. And then
Okay.
we'll look to the dental history. Do you have an oral appliance? How has that been looked at? Are you aware that you're clenching overnight? Are you now sleeping in different bedrooms from your partner because of that sound of teeth grinding? So
Sure.
that's what we're going to look at for there. Back to sleep position. You know, your example was 4 hours of sleep. I think we're all going to accept that that's not enough sleep to be getting. So are
Sure.
they not getting meaningful rest? So now their nervous system is upticked. And maybe this is minor. They have fibromyalgia patient. Is this kind of a global thing for them that they're having all these pain issues because they're not getting meaningful rest? And then, for sleep as well. Yeah, I sleep on my stomach. Okay, well, you're going to sleep on your stomach. You want to breathe. You're going to tilt your head. You're going to engage SCM. How's that look? Oh, not to
Hmm.
categorize any group, but typically our younger folks too, they've grown up with technology. They typically have SCMs that are engaged because they're looking down into their lap, cell phone, laptops, tablets, that type of stuff. So that's
Sure.
kind of what we're doing to their responses. It's because we ask so many questions. It's not like, oh, this hones me here, this hones me here. You just get a
Yeah.
snapshot. You can get a pretty good sense of just looking at that. Where are the red flags? It would be the same as like getting blood work and a lab report comes back and you're like, this is out of ordinary. This is out of ordinary. This is something that is guiding us to what we're going to think before we get in the room with the patient.
Sure. And on the topic of red flags, like, are they saying anything that you're thinking this person should not be here with me right now? It's probably best I send them elsewhere.
To a degree, the thing about oral facial physical therapy, and that's something that we're trying to change through both my practice and the CCTT organization, is that PT is a direct access state, and we're concerned, or is a direct access profession in most states. And what we should be doing is we should be the first line of defense because we are conservative care. For oral
Sure.
facial pain, we don't see that as much as we would see back pain. Most people
Hmm.
with oral facial pain, they're going to go to their dentist. Dentist is going to depend on how comfortable he or she feels treating it. Oh, maybe you need to go to an oral surgeon. Oral surgeon, if they're not a surgical candidate, which most patients aren't, they're going to refer to ENT. So these people have been bounced around a little bit. So while it's frustrating to the patient, it does make our job a little bit easier because we can rule out that stuff, those red flags, as you had said. To speak to that point, if a patient comes in and says, Ryan, my ear hurts. You treated my neighbor, her ear hurts. You got her better right away. Let's do this. My thought to that person would be, well, let's go to an ENT. Let's make sure that you don't have an ear infection because all the physical therapy on the planet is not going to cure an ear infection.
Yeah.
So we don't see a ton of red flags insofar as that, a lot of times because they have seen other professionals before they've seen us.
Yeah. Okay. And that makes a lot of sense to me. So I know that headaches is a common question for necks, for people with
Mhm.
neck pain. Are there specific headache types other than the temporalis headache that they're like, man, I've been getting headaches. Are there any specific headache patterns that you're looking at more oral facial, like anterior neck structures?
Yeah, so the one that I always give in the office, especially when I have the Travell poster of refer to oral facial pain hanging in a couple of our rooms. The example I'll give a lot is patients go, "Gosh, I have neck pain here all the time. I beg my husband to rub it, and he won't. I get these patterns. I get this headache, and it comes like this." And they'll trace the ram's horn pattern in the office, and then you show it to them on the wall, and they're like, "That's it." Or some of the sinus type of issues, that's typically what we'll see a lot. And patients are really just very happy that you connected the dots of, oh, I didn't even, we use a standard, the TMD disability index for our patients. And some of our patients will say, gosh, I didn't even realize that this would have been connected. I've had headaches, but I never realized this could be connected to my jaw. I've had ear fullness or pain, but I didn't realize this was connected, dizziness along those lines as well. But to answer your original question, temporalis is a real dead giveaway. Suboccipitals, and then sinus region, pressure around the eyes. Those are typically oral facial, things that lead us to this is probably an oral facial issue.
Sure. And I think a lot of people listening, especially if they're providers, are familiar with like the ram's horn presentation, like
Mm-hmm.
suboccipitals headache.
Mm-hmm.
The sinuses, where are you thinking if they're like, I get sinus headaches or behind my eyes, where does that point you?
So SDM has got a pretty gnarly referral pattern. It's kind of all over the place. Like I said, apex
Okay.
of the head, right over the eyes here. So you'll get some of that. It basically, they break it down by sternal and clavicular head. But when you combine those pictures, I mean, almost the majority of the face is read that way. So that's kind of my go-to, catches a lot. Some of the ones, in the sinus area, this would be zygomaticus. Now that zygomaticus is a little bit different because that's innervated by the facial nerve versus most of our muscles of mastication, which are trigeminal nerve innervations.
Sure.
So we'll look for that stuff. But really, for some of that local in here, it tends to be not that really unique ram's head pattern where it's trigger point down here, could be pain up here. When we're in here, you're pretty spot on. The pterygoid's referred pattern is real close to where those muscles are. So that's where I would hone in for those. Kind of, if you're in this sinus region, it's probably those muscles right around there.
Okay. Excellent. I appreciate you entertaining my detour. So
No,
you,
for
you were
sure.
saying you were saying the assessment. So you get that snapshot and then you jump into the assessment and you're doing what?
So yeah, the objective. I think I'll
Yeah,
do
yep, the
just like we
objective.
normally would. Cervical range of motion. See how that looks. We do quick, screen overhead, shoulder screen, that type of stuff. We'll look at patterns, opening patterns. We talked about that a couple of minutes ago. That is
Mhm.
one of the things that is typically overlooked by the dental community because by the time the dentist gets in there, patient's leaning back in the chair, mouth wide open, dentist looks in. As physical therapists, we study not only range of motion and strength, but fluency of motion, right? Can you
Mhm.
move without ataxia? Can you move without kind of that cogwheel pattern? So that's what I'm looking for. Just how do they open natural? I say, open your mouth. Do you want me to open it far? Or do you want me to? No, I just want you to open it. What are you comfortable with? That's what we're looking for. We're seeing how apprehensive they are to do that type of stuff. So we'll do, a kind of an external screen, basic PT 101 stuff, range of motion, that type of stuff. Jaw open, close, lateral excursion side to side. And then we'll also do kind of a palpation, extra oral, all the neck, all the facial stuff. And then I'll typically get them on a table as supine. I usually just take 2 tongue blades, pull their cheeks apart, take a look. Take a look at how their teeth come together. Are there just obvious signs of, gosh, I probably would say the layperson could probably see these teeth just don't look like they're coming together normally. They have an
Mhm.
overbite, they have an underbite, they're missing a bunch of teeth. They don't look like they take very good care of their teeth. Their mouth is all covered in sores. You can tell that they're excessively biting their cheeks, that type of stuff. So we'll just get in, we'll take a look at the tongue, all of that stuff, just basically observation. And patients will tell you. You start palpating, their eyes give it away. Hey, that really hurts. Pterygoid's an easy one. They'll do one of those squint type of things for when you're touching it. So that's kind of how we're doing it, which is really one of the take-home messages for anybody who's listening to this and has any sort of like, gosh, it kind of interests me, but I don't know that I could do it. The TMJ is not very different than your shoulder, for example. They're all the same physical therapy principles. It's range of motion, movement. How is it? Okay, this doesn't move well. Okay, what causes that movement? Is that tender to palpate? Do we see restriction in the antagonist? That type of stuff. It's unusual because of the spot in the body, but it's really very successfully treated with all the physical therapy stuff you're doing for the other parts of the body. And to your point, the evaluation is similar. We do those basic principles a little bit more because we have some other structures around there, but the basic principles are pretty much the same across the board for Pete's sake.
Sure. So just kind of recap. So you're essentially screening out active cervical range of motion, just rotation, side bending, flexion, extension. Yep. Oh, I apologize. My St. Bernard is giving me fits. Days you can't hang out with us. So you're doing cervical range of motion, and then you're looking at jaw opening, jaw closing. And when I think back to PT school, they had us get out rulers and measure like these deviations from side to side. Are you finding that it's really clinically useful to do those measurements, or is it just like, I see that it's a little this way, a little that way, and going off that? Because they would always they're like, measure the teeth, measure the millimeters.
Yeah.
And, it doesn't take much error to be off by a couple millimeters.
Yeah. So I guess the gist of it is probably if you want to get reimbursed by insurance, you should be taking the measurements because that's what they're going to look at.
Sure.
We have just they're bite scales. They're this big. They're paper scales. We buy them from a dental company that does them. Put it in, check it. It would be like a disposable goniometer of something first. That's really the main one that I'm going to look at is opening, and just to get a sense of, but patients will tell you, gosh, I don't feel like I can open my mouth.
Sure.
There's some pretty standard kind of quick and dirty. So 20 millimeters. So we call it incisional opening because your front two teeth are your incisors. So 20 millimeters or less is going to be trismus, which is also called lockjaw. You're going to need 30 millimeters for most dental procedures. And then your traditional scale is going to be 40 to 50 millimeters. And that's going to be dependent on size of the patient, size of their mouth, that type of stuff. But that's a pretty quick and dirty of where are we here. I get a female patient who's got some pain, doesn't feel like they can eat, burger, salad, something like that. They're at 34. I'll say, okay, I think that you would be a lot better if you could get 5 more degrees. Now, am I hounding those 5 degrees like I might be a post-op total knee replacement? Not necessarily, because I want function and I want the patient to say, hey, this is what's normal to me versus you need X amount of degrees to walk up and down the stairs. You just have to have that. So we do get, I'm not a real stickler for the number, but I do like to get a sense of how close are we? Where are we there? Just like most things, if you see a lot of shoulders in your practice, you can eyeball shoulder range of motion, within 5-10 degrees. Millimeters, you can be a couple off. We'll get the specific measurement because there's not as much room for error, but I will measure that. Typically incisional opening. I'll take a look side to side and protrusion, but incisional opening is usually what drives patients in there. I can't open my mouth to eat.
Got it. So that's the objective portion. Is there anything that I missed in my recap that you'd like to add to? Oh. Can you hear me, Ryan? Can you hear me?
I think the lag caught up. I think you were talking about.
We're caught up now.
I can now. So
okay.
we're good now?
Yes, I think so. I was just saying because I think that, like you said, it sums it up. It's PT 101. Like, we're looking at range of motion. We're looking at limitations. You're then palpating the structures that cause that motion and seeing if it is tender or its antagonist is limited, and you're starting treatment.
Yes. Give me 1 second.
Sure.
So yeah, I think that the question was, I believe, what are we missing, or what are the other components here?
Yeah,
And
like
really, what I think,
or if there
one of the biggest
one
component of it. I missed that last part, Nate. Go ahead again.
That's okay. I think we're just lagging a little bit.
So I'll just kind of go over it. So the educational component is really a big part of the physical therapy treatment for oral facial pain, mainly because of what we talked about prior, which is that it's not necessarily an injury that was caused by, direct trauma or something like that. It's usually the culmination of these smaller irritants. So one of the things that we have to do is tell patients, you need to start reducing some of these irritants in order for this to improve. The jaw is one of those challenging joints because we don't really give it a chance to rest, right? We eat, we talk, we breathe. We're constantly engaging those muscles, so we don't give them a chance to, quote unquote, rest like we would some other muscles of the body. So one of the big components of my evaluation, or me specifically, is I very rarely treat the first day, because I'm really trying to hammer home how important their role is in this. We can probably get some knee replacement patients better, some ankle sprains better, just by doing the stuff in PT, and they come and they can do their stuff. Oral facial, I personally really emphasize right off the beginning, this is a team. I'm going to do 50% of this. I'm going to get you under control, but your job is to reduce these irritants so that you can stay out of the office. The educational component is much more important, in my opinion. I've been a therapist for 22 years. I've done oral facial for the last 8. It's much more crucial for success is to get that patient buy-in, to get them to stop, to reduce the irritants. Probably a question will be, well, what are the irritants? Most of our patients are driven because they're clenchers, grinders. Their muscles are engaged. One of my standard things is, you come in for knee pain, I'm going to tell you, let's strengthen that knee. Let's build up the stability. Let's take the pressure off those two joints. You come in after shoulder surgery. All right, let's get that range of motion going. Let's get your shoulder overhead. You come in for oral facial pain. It's kind of like, stop doing everything. This is typically a diagnosis of over muscle engagement. So we're trying to turn it off. Let's get your teeth apart. Let's relax. Let's de-stress. Let's work on how you're calming down. Let's work on your posture. Let's work on reducing these irritants. And that's one of the things that is crucial, in my opinion, for success in oral facial physical therapy.
Awesome. No, that's very helpful. And it leads me to, I guess, another part of the objective when you're looking at this patient, because you just brought up posture, and I'll try to get situated here without shaking my camera too much. Like, are there different positions that you're like, man, that person is more prone to either upper cervical or TMJ issues? Like, if they're sitting here, we talk about forward head posture a lot. Like, if if they come in and they're sitting there, they're like, Ryan, I can't open my mouth and everything hurts. Are you like, well, we need to address that posturing?
Absolutely.
Like, how big?
Absolutely.
I guess my big underlying question is, how much does posture impact oral facial pain?
Significantly. I would say that it significantly impacts it. And I will say that the majority of patients who come in are aware. What I hear all the time is, we'll talk about my posture is terrible. I know it is. I'll say, all right, we got to work on your posture. And everyone sits up real erect in the chair. Most of the patients are aware of it, but being able to directly tie that together. I know that you think your computer's not set up right. I'm confirming this. You need to fix this. You are responsible by the next time we meet to either get a remote keyboard and a mouse, spend $20 on Amazon Prime, get a remote keyboard and mouse, get your keyboard up here. You will be surprised how many people have been home from COVID and are still working on their laptop at the edge of their couch on their coffee table. Stuff like that. When you're hunched over like this, we know that that's going to put forward head posture. Not only does it cause the strain on the neck, and when you're looking down, it puts your puts your teeth in a position to be closer together. And that's what we're trying to avoid. So posture is very, very important for facial therapy in the majority of cases.
Cool. So like you said, your first day, you're assessing, you're looking at everything, but the big part first day is education. Again, stress management. Like, if these people just locked down all the time, like, are they just over tight around the jaw and face because of any number of factors related to posture, ergonomics, stress, and other things they enjoy doing? When you do get into treatment, could you maybe provide, I guess, first off, people are probably wondering how long, more or less, I know this is a difficult question, how long is it going to take someone, if they listen to what you're doing, they organize their ergonomics, they start to work on their posture, they start to address these things, what is a general timeline to start noticing changes? Like, are they going to notice changes in a couple weeks? Is it going to take a couple months? Or is it going to be one of those longer term, since it built up over a long time, it's going to take 6 months to really notice any changes?
Absolutely. So one more thing. I want to close the loop on the last part of the eval.
Sure.
One of the good things about PT for oral facial pain is that most of the time, people that have had this and have seen other providers have had just reactionary type of treatment. Oh, your dentist says you clench. Here's a night guard. Oh, the night guard didn't work. Go to the oral surgeon. Oral surgeon says, I don't think so. Maybe let's try a course of steroids. That didn't work. Go to the ENT. ENT is like, here's some ear drops. That didn't work. This PT, he treats this here. When you can sit in the first day with them and say, this is what it looks like to me. This is what we're going to do. We're going to do this day 2, and then we're going to see how that works. And then day 3, we're going to make adjustments. And day 4, we're going to make adjustments from that. That sort of buy-in, that patients now see that they're part of this process, and you're just not saying, here, do this, and it should be better. There's a lot of buy-in because they've been bounced around. So that really is an easier sell for patients, because now they feel like, hey, he's doing his part. I need to do my part in order to help this. So that, to kind of summarize that up, is really good for buy-in, just because you're the first person. The best compliment that I get, and I am lucky enough that I get it frequently enough, is that I've learned more about my jaw in the past hour than I have the past 30 years. How come someone didn't send me to you sooner? How come no one else explained this to me? When we can take time, in one of my lectures, I say, it's a famous quote from Osler, listen to your patient. He's telling you the diagnosis. When someone can sit and do this, patients are blown away, and that's immediate buy-in. And then what we'll typically say is, again, everybody's going to be different. We typically see our patients in the office twice a week for a month, and then we try to go them down to once a week for another month. So that would be 12 treatments. Unusual for some physical therapy. What we'll find is that patients have had this for so long, they've gotten better, that they don't want to leave therapy. They go, well, can I keep coming just once a month? I just don't want this to get worse. This is the best I've felt in years. Can I just come along? So you don't get that with a lot of your ankle sprains. Oh, I'm just going to keep coming so I don't sprain my ankle. So that's a good benefit from that. But yeah, everybody's different, but that would be kind of the quick and dirty. That's the timeline that I will, have the patients mentally prepare for. And cool. I think you actually said, when are they going to start seeing results? Much like just starting any exercise program, the first 2 weeks, if they're not worse, they're better, because they're saying it hurts here, and we're palpating, we're doing all this stuff. We're trying to get through that muscle guarding. So after the first 2 weeks, most patients will say, gosh, I am noticing I can open wider. I can definitely open wider when I leave the office, that type of stuff. But that's a kind of general time frame.
Cool. Excellent. So if you wouldn't mind, I think the last thing we really need to get into is what are we doing for these patients? Like,
Sure.
I've worked with clinicians that do like upper cervical manipulations, that are doing pterygoid releases, that are dry needling.
Yep.
Like, if you wouldn't mind going through kind of some of the biggest interventions you do, or most common, and maybe what shoot. And this is where it gets hard to tie it all in because there are a number of things you're treating. If you could maybe give me 3 of the examples, maybe you talked about the masseter is a big one. You talked about temporal headaches is a big one. You talked about jaw pain is a big one. If you could maybe give me a category that you have decided you're going to treat based on the things they tell you, and maybe some introductory things that someone could attempt, because really I think the biggest benefit people that are listening to this are going to get is by reaching out to you or pursuing mentorship or kind of just kind of reaching out to someone like you to get more answers if they see this often. Yeah. So if we could maybe categorize a few and basic interventions.
Sure. So the first thing is we're a pretty manual clinic. We have how our clinics are broken down. We have about 25 minutes of one-on-one in a room time with each therapist, with each patient. So that's the time that we're kind of going over kind of, hey, how did you respond to the previous treatments? Typically doing it while we work, because I do cover a lot of areas. I will go kind of upper trap, cervical paraspinal, suboccipitals. We'll do some up and down glides. We'll do some manual traction. I'll go to the front, do some soft tissue of SCM, go under for the suprahyoids, come around external masseter, external temporalis, glove on. We'll go in the mouth. I'll do some masseter, intraoral. We'll do lateral pterygoid release, and then we'll do joint mobs. Jaw joint mobs are typically done by resting your thumb on the mandibular teeth, which are going to be your bottom teeth, and then you're just going to mob kind of like you would a shoulder. So to kind of tie all yours together, the home runs that I typically would go, if I said, hey, this is a jaw pain patient, you can do 3 techniques or whatever techniques, what gives you the most bang for your buck? Suboccipitals. I think that suboccipitals are a huge key. When you chew, you think of opening and closing your mouth, but there is an extension flexion component of the upper cervical spine. So we find that those are, even the patients who say, yes, my neck always hurts, they go to upper trap because that's low hanging fruit, but really suboccipital is going to give you the most bang for your buck. In my experience. Next is SCM. SCM's got a huge referral pattern, as we've talked about a couple of times. Don't be afraid. You can take a big chunk of SCM. SCM's a big muscle. Don't just superficial it. You can really, like, if you dry needle, take a big chunk and go through there. Masseter, usual culprit. We can do that external, and then the pterygoid release. So pterygoid release, if you're not familiar with it, basically we'll take a small finger. I use my pinky. We'll go up along the the maxillary teeth right to that pterygoid space and just kind of press. You can't get a good purchase on the muscle because of the anatomy of the skull. So you basically end up just kind of applying pressure to it, but it's still a very effective technique. So I would go suboccipitals, SCM, masseter, pterygoid release. Those would be like the 4 that we use the most.
Sure.
And then just to add in a 5th, I guess my list is getting longer, but joint mobs is a huge one. If a patient comes in with trismus and they're just not opening their mouth, it would be exactly like coming with frozen shoulder. If a patient comes in with true frozen shoulder and you're working with them and you're stretching them and you can tolerate, you're like, this is just going to get better. We're going to go from 70 degrees flexion to, 120, 130, 140 in the first month. And this patient's going to be significantly better. Somebody comes in with just locked jaw, no specific dental problems. We know that if we can stretch the capsule, not just stretch the muscles in the capsule, you're going to be significantly better.
Okay. That makes sense. So, or I got to organize my thoughts here for a second.
Yeah.
Um, so how often, because you had brought up dry needling, I'll kind of go in order. I'll ask a few questions that people may be wondering about. So the suboccipitals, do you often choose to dry needle them, or are you often doing like a supine release of the suboccipitals?
So probably like most of us who are dry needling, we're going to that after we've done some manual stuff. We want to see how they respond. Much more
Okay.
than the calf, for example. You can really hammer on a calf or a hamstring or something, and patients have a good tolerance. When we're in their facial region, it requires a little bit more delicacy with it. So we'll get into that. But I will do, if it's something that I'm very specific for. We talked about ear fullness and those specific muscles. I will get into dry needling sooner. I typically don't in the first 3-4 sessions. I just want to see how they're going to respond, because if they're real sore from just me palpating, they're going to be extremely sore from dry needling. So we'll go into that. But I do dry needle suboccipitals all the time, SCM all the time. Lateral pterygoid is one that takes a little bit of confidence. You might have to practice on some of your coworkers or staff for a little bit, because you'll take a 50 needle and you'll go straight in. You find open and close, you find the mandibular condyle, and you're going to go into that mandibular notch, and you're going to go straight in to get pterygoid that way. So it's one that takes a little bit of confidence, but very effective. Completely trainable to do. You just need a little bit of practice to do it.
Sure. So
that, of course, is one that I don't get to immediately.
Yeah, no, I can imagine you pulling out a 50. And for anyone listening, a 50 is a 2-inch long dry needle.
Yeah.
And they're like, what are you going to do with that?
Yeah.
And you're like, oh, I'm going to stick it in your face.
Like, straight in your face this way too.
Yeah. So, okay. So,
I will say, Nate, before you go on,
sure.
The thing about oral facial pain, though, is that these patients, if we've done it right and we've kind of educated them off day one, they have such a buy-in that I would say the example is, you could tell a patient, I want you to stand against this wall, open your mouth, I'm going to take a fire hose, and I'm going to blast it right in your mouth, and that's going to solve it. 90% of my patients would be like, if that's what you say, let's do it. They're at the point where they're looking for anything. They'll say, oh, gosh, I don't want a needle in my face, but I don't want this pain. Let's do it.
Yeah, true. I wasn't really going to go on. I guess I'm wondering the best way to, because I think you hit some awesome things. We're hitting the suboccipitals, we're hitting the SCM, we're hitting the masseter, hitting the pterygoids, doing some like TMJ joint mobs, some either distraction, or so if you do distraction, do you also do like anterior glides on the TMJ very often?
What I find I'll do more than that is lateral, because of lateral pterygoid, and lateral pterygoids will laterally excurge. We'll call it lateral jaw excursion. We can find that we can stretch a tight lateral pterygoid that way, because with the release we just talked about, we're just kind of getting to the muscle and pressing on that trigger point. We can't palpate it really well like we could other muscles of the body. So I do like to kind of go that lateral direction to stretch out lateral pterygoid. Remember, it goes the opposite direction. So if we want to stretch our right pterygoid, we actually have to go to the right to stretch it.
And same thing. You're going to grab the mandibular teeth and you're going to essentially just deviate them towards the side of tightness.
Yep, absolutely. It's really nice when you can get a good purchase here. I'll go one thumb in, this under, a couple of my fingers. Let me turn this way so you can see under the jaw. So I have a really good way to manipulate it. I want that patient to feel that I have control. What you're going to find all the time is patients say, gosh, I feel like I can't relax. Well, of course, that's why you're here. You're a clencher. So we know that coming in, but we can get a good mechanical advantage to do that. But if you kind of are just, haphazardly, they're going to control it with their jaw muscles because they're typically already engaged. If you can give them that point of security, another hand bracing their head, give them that head. The therapist feels like they're in control and just moving what they want to do. You'll get some good results with that approach.
Sure. So I think what I'd like to do is I'd like to just go over one specific case with you.
Sure.
Just treatment more because we've already covered the subjective and objective portions. You say that a lot of people are coming in because they cannot open their mouth.
Sure.
That's a big one. Like you said, that's one you measure most. So someone's coming in and they cannot open their mouth.
Okay.
You had went through those 5 things: suboccipitals, SCM, masseter pterygoids, joint mobility. So someone cannot open their mouth. Run me through what you're going to do with the suboccipitals on the first day of actual treatment.
So for first day of actual treatment, if they can't open their mouth, I'm going to focus more on oral facial. So almost just like a frozen shoulder, I'm not going to think, oh, maybe this is lat, maybe this is middle trap. Yeah, could those be contributing? For sure. But I'm going to go with, what do I think the big cause is? I think the big cause is masseter tightness, masseter engagement, and then joint capsule tightness. So we've already gone through, we've talked to the patient. Keep your teeth apart. I want to make sure throughout the day you're conscious of your teeth position. Make sure that your teeth are constantly apart. One of the unusual things that most people don't know is that your teeth are never supposed to touch. So your teeth are never supposed to make contact. Even when you eat, you have food in between them. So your teeth are not supposed to touch. So most patients will rest their teeth together. I'm not clenching, but in theory, what they've done is they've brought their teeth together. So even if your teeth are resting, the resting position is supposed to be with a little bit of space. So you're mildly clenching. It would be like saying, I'm not making a fist. Well, right. Those muscles are still engaged. So that's where my educational purpose comes in, right? Be conscious, disengage those muscles as much as you can. So you come in with limited mouth opening. What I'm going to focus on that day is masseter. I'm going to work on masseter and temporalis. Those are 2 of the jaw closing muscles. I'm going to try to work those out, work out those adhesions. I'm going to do that externally and then intraorally as well. And then I'm going to do some joint mobs. Okay. And then we're going to send the patient home with, hey, can you either self-stretch this way? We can stack some tongue blades together, popsicle sticks, have them kind of form like a wedge there. Dynasplint, they make some other stuff. It's a little bit intrusive and expensive, so we can really kind of get away with just some self-stretching techniques. So that's what I'm going to be for sure. That is one of those that most patients are going to come in with, let's say 21 millimeters. They're going to leave with 31 millimeters. I mean, we're talking about a 50% improvement. Now, they're going to leave the office. They're going to go 29, 28. They'll go 3 steps forward in PT, 2 steps back, 3 steps forward, 2 steps back. But that ability to see, hey, this is getting there. My jaw can get there. That's very, really helps patient buy-in for sure.
Sure. So my last question on that example is, so you say you're going to do some tissue, like you're going to work on the masseter. Are you doing something like ischemic compression? Are you just kind of digging into it? Are you, what exactly are you doing to it to work on it?
So for sure, that is something that has become kind of therapist preference. What do you like? I will do, aside from what I'll typically do with the masseter, because it's really only the breadth of my fingers, it's hard to cross friction it because you're kind of right. You're at the beginning end. So what we'll typically do is work along the fiber length, break up those adhesions and kind of stretch it out as well. I'll do some active release type stuff where we're, hey, let me go down here, open with me simultaneously. And that's what I'll typically like. You'll find that most patients won't tolerate that direct ischemic pressure for the 30 seconds, that prolonged. So when we can kind of do this type of stuff, and especially when they're, we're working on their masseter and that's really tender, when they start opening their mouth, just like with other body parts, oh, I have a job to do. I'm not going to focus on the pain. I have to open my mouth with it. And we'll find that we're able to get them to do a lot more because they're not focusing on, holy smokes, this really hurts. It's, okay, I have to open my mouth with it. Oh, I am opening wider. So that's what I'll do a lot for masseter that way.
Okay. And when you do, like, let's say you're digging down into it or you're doing some
Mhm.
active release, what are you doing intraorally? Are you just
So
grabbing
we'll
it
do that.
inside and outside and
Yep.
just kind of,
So we'll go kind of an okay grip this way.
okay.
Glove on, obviously. We'll
Uh-huh.
do thumb on the outside, index finger on the inside, and then basically we're doing the same thing. We're just getting
Mm.
it, superior to inferior is typically how we'll do it this way, just to give it that backboard as well. And good results with that for sure. So I will do
And
both.
is the answer. So what are
Yeah.
you doing generally as dosage? Because I've heard a lot of PTs, especially those who do manual, they're like, do it until you feel a change. But for people that are just getting into it or just out of school, they're like, I'm not sure what that means.
So the good and the quick and dirty for that is if you have, and a lot of these patients are going to have the multiple comorbidities. Gosh, upper trap, you're triaging stuff. Upper
Hmm.
trap is super tight. Suboccipital is an issue. SCMs, it's kind of the whole thing. So
Sure.
what I will typically do is kind of shotgun approach it. A little bit of everything. Let's see what I feel. Let's see what the patient reports after that. That's when I treat day 2, day 3. Hey, what worked? Gosh, this was really sore, but gosh, I could feel it. I feel like my neck's okay. The patient will really guide you pretty well to do it, of where you want to hone in. And that goes back to what I was speaking about before of them being an active participant. So they like that. Hey, I think this was
Sure.
effective that way. So that's what I'll use some of that to see what can they tolerate. Patient comes back, says, gosh, after you worked on me, that was Tuesday and it's Friday and my jaw's still sore. Well, we know that we have to kind of shift our focus a little bit. Again, PT stuff that we're doing on scapular region, for example.
Hmm. No, sure. I think my question more is like, if I'm sitting there, I get someone coming in and I'm like, I'm going to work that masseter. Like, if I'm sitting there working on it for 10 minutes, I've probably blown past what I probably need to do.
For sure.
Like, are you finding that, you just kind of do that technique for about a minute or two or about 10
Yeah.
or 15 times?
No,
Do you really have a preference?
I typically will do definitely not more than a minute per area. I don't count strokes. I don't kind of do I'm not like in my head going 3, 4, 5. Okay, now let me do 5 on the left that way. Just like a lot of stuff we do in PT, it's just how you develop your touch. But yes, your point is very well taken. How does somebody who doesn't know how to do this, how do you know what to do, what not to do? I've always operated on the philosophy of oral facial pain is I can always do more. What I can't do is take back over doing it. Patients are coming
Sure.
there to feel better. You rock them and they come back and go, I couldn't eat for days. Like they've lost confidence in it. Start real
Sure.
simple. Say, hey, let's just start. Let's see how we do. Cover that area. If you're really a stickler for numbers, 30 seconds per muscle going, simultaneously. I've said I'm going to hit 10 muscles. That's 5 minutes already. You can maybe make that to a minute. That gives you 10 minutes of manual.
Sure.
So I think that's probably a very vague answer to a question, but I would say, 10, 15 strokes, 30 seconds to a minute each part, move on, and then see how they
Sure.
respond and build tolerance.
No, I think that answers the question exactly. Because a lot of us in PT school are like, how long do we do it? And they're like, well, it depends, as
Yeah.
long as you feel you need to. And it's like knowing that you're looking about 30 seconds to a minute of just working it.
Yeah.
And then again, see how they feel. If they come back and they're like, holy crap, you rocked me when you did that for 5 minutes.
Yeah. Yeah.
Again, that buy-in that you worked so hard for a whole session to get, it starts to deteriorate.
Yeah.
Um, I would really like to ask you about this one more thing. And,
Mhm.
my takeaway, I hope those listening will probably feel the same way. Like, yes, it is basic in principles, but it's really helpful to have someone like Ryan to just reach out to and to know what he knows, maybe get connected with him, go to a class if this is something you treat regularly. Because I feel like I organize my thoughts pretty concisely with most things, and I'm having a hard time grabbing like, what about this? What about with that? What about this? So for anyone listening, your best bet would really be to take Ryan up on his offer, shoot him an email, message him on social media, and really get connected into this network. But I find, going back to what I was going to say about treatment, a lot of people are a little hesitant about the SCM. Like you said, they kind of just are like, oh, I'm just going to grab a little bit of it. And I think a lot of people are taught that or feel that because the carotid is under there.
Yeah.
And so can you go into maybe what you would do for the SCM before you get to needling, and maybe give people a little more confidence to grab that sucker and do something to it that can create meaningful change?
Yeah. So I think, and to your spot about your point about the timing, that was one of the questions when I was trained myopane seminars for dry needling. You were at St. Augustine. I don't know how they did there, but that was my question. How many strokes do you do with the needle? What's like the right thing? And everyone's kind of like, you just figure it out. And you're like, I don't know. And then you just end up figuring it out. So you get some sort of, do 10. Okay, then see how that goes from there and get onto your thing. So that's a good point. And that was, in my past, that was a question that got brought up. So for SCM, I typically work with patients in supine, me sitting above them at the top of the plinth, at their head. Mm-hmm. So I'm kind of around them this way. In general, SCM is, you can take more than you think you can. And we talked about that earlier. Obviously, you got to be mindful of the carotid. And the only other thing that I'll see is I have bigger hands, so I tend to work bilaterally. The only thing is when you're getting SCM, you're going to stretch that skin right across the trachea, and that can be uncomfortable for a patient. So sometimes you want to have them a little bit askew. You obviously don't want them to have them rotated because then you have SCM engaged. But you can really take a good chunk of it. I do tend to work probably on the superior half more than I do the distal, for no other reason than that's where I typically get it. When you start to get up by masseter, then you get posterior digastric coming through. You get all the cervical muscles that have mastoid attachments there. So that's typically where I'll see more of the results. And you can't grab as much SCM as you get more proximal. And then you have to go from basically a pincer grip to a flat grip. And again, I'll typically go length of muscle that way to work on it.
Sure. And so if for anyone wondering, because we did bring up the carotid and everyone's like, what do I do? How are they going to know if they grab too much? Is it going to be like, what really happens? Like if they grab too much and they, get a big chunk, like, is it just going to be uncomfortable for the patient? Will they pass out if, they're like,
well, if they pass out, you have too much.
Okay.
So that's it. But in general, I mean, patients are really going to tell you, hey, that's uncomfortable. It's going to be just a palpation thing. It's from the oral facial requires more manual, I would say, than maybe an ankle sprain. An ankle sprain, I'm going to really stretch into dorsiflexion, and that's going to be my go. We'll do calf stuff that way. But there is a much more manual thing, and it is a feel to it. It's not necessarily a feel of, I got to get the oral facial feel, which you do, but it's just having your hands on patients in general, being able to read, hey, what's too much for them. The good thing about it is you're right by their face, and their face is going to tell you. They're going to do one of those. You're going to see the eyes clench. You're going to see the jaw clench. They have a real good tell, the vast majority of patients, and you're right there. You can't avoid looking at it. So that's really the easiest way. They're nonverbal cues. I mean, patients are going to tell you, but it would beyond that nonverbal cues. You're so close to their face that it's really hard to kind of miss.
Sure. So, for any of those out there listening, like you're probably going to notice them wincing, like tightening, the wrinkles around the eyes, or they're going to tell you it hurts before you grab enough of their carotid or anything else that you're going to make them pass out or anything bad happens.
Correct.
Okay. Good to know, both for my
obviously
knowledge
without saying it goes, be cautious of that.
Sure,
we'll put the little asterisk of yes. I'm not saying you just go for it. You're not going to do it. In theory, it's just like needling. Be cautious of it. Know where the structures are. Be cautious of your pressure. Be cautious of, both verbal and nonverbal cues from your patient. But in general, you're going to be able to get away with a lot more palpation of SCM than you probably would think you could.
Got it. So last thing before we wrap up, I know I've said that a couple times, but people will be curious. We were taught tell me your kind of process for dry needling the face, either the masseter, the pterygoids. Are you a put it in and piston? Do you prefer to put it in and wrap it? Do you prefer to just put it in and leave it? What are you generally finding is your best technique for addressing these different muscle groups?
So I'm a product of MyoPain seminars for dry needling, and MyoPain is primarily a piston. That's the technique they show. Okay. And I was certified oral facial by Jan, so that's how he's done it. MyoPain is actually geographically 45 minutes from me, so that's convenient because I do take a bunch of coursework there. I do know that they have started to do some stim, that they have started to teach stim, which they didn't. Some of the therapists in my office are educated that way. EIM, I think, does it that way. So I have picked up those techniques. In general, when I'm going to do a pistoning technique to kind of be able to go through as much as I'd like to do in a timely fashion and not have a patient kind of, gosh, this sucks, and it's now sucking for 10, 15, 20 minutes. That's my go-to. Patients that can't tolerate it, or if I'm really trying to wake up a muscle or turn something off, I will do some stim. We will typically do the pointer stim. The alligator clips in the oral facial region typically are too heavy because you don't get a lot of tissue. So it's not in very deep. You put an alligator clip on, it starts to vibrate. You're going to find that it's going to vibrate it right out. So for the stim technique, I typically will just use the pointer versus the alligator clips. But to answer your question, I think really I go piston is my go-to, especially in the cervical spine or in the upper cervical spine. And with the facial as well, I'll add more stim. I don't leave them in and kind of either twist them or leave them, probably just as a result of my training, for no other reason than, hey, this is more effective than not. I haven't seen anything in the literature that says yes or no. So I think that's just kind of my go-to, which again is really a product of my training.
Sure. So that makes sense to me. Like masseter, you're gonna piston. SCM, you're gonna kind of get a lump of it and piston. Pterygoid, you're going to piston as well. Are you going for if it's the masseter or the SCM, are you going for a visible contraction? Are you looking for a contraction? Are you just feeling around?
You're not gonna get as many contractions as you will upper trap, right? You get that right spot in upper trap, it's a fireworks show going. You're pistoning, it's twitch response. You're not gonna get that as much because there's just not as much physical tissue in the oral facial region. You for sure will get it. When you go in for the deep one for lateral pterygoid, you'll typically get a twitch response or two because you're going through all the layers of masseter through there. It won't be that big pop, where you can kind of actually see the body move. But yes, I'm ultimately looking for that. I'm still looking for twitch responses, although just on a smaller scale.
Sure. And I guess the last one, because related to dry needling, is do you have preferred sizes that you use for different muscles before we finish up?
Sure. I use the standard muscle that I'll use for the cervical spine is 30 millimeter or 30 diameter and 50 length. Okay. And then for the oral facial, I go down to a 30 length, and then I go to a 23 diameter or 0.23. So you want to try to have the thinnest girth as you can because this is a much more sensitive region. Me personally, anything under 0.23, I don't feel like I have control of the needle. I feel like when you hit something, it's almost like a hair. You'll get that bend. Yeah, exactly. So I've found I use Serin brand just out of habit if nothing else. But they make a 30.23, and that's what I'll use for oral facial more than anything else.
Okay, awesome. Well, I think that's all the question I've got for you, Ryan. Here's your chance if you have anything you want to add, any plugs, any things you'd like to share with the audience, and then we'll finish up.
Yeah, absolutely. So I mentioned before, I've been a therapist for 22 years. if you told me 22 years ago that I was going to spend the majority of my day with my hand in someone's mouth, I would tell you you're out of your mind. It's not a path that I went to or that I really ever saw myself doing it. In my opinion, for how physical therapy is going, especially in my region, I wanted to have a specialty. I didn't know exactly what. A lot of credit to one of my mentors, Mike Harrigens, who's out of Wisconsin. He was a great mentor of mine. It was the first class I took and really turned me on to how not easy it is, because there's a lot of nuances, but how you can really do this and have an impact and really make a name for yourself as a oral facial specialist, just applying all the techniques that you have already from your physical therapy. It falls in this black hole of PT that nobody's really confident to treat it, but it's really not that hard once you get a couple of reps under your belt. We didn't even talk about this. Nate and I talked about this before we got on camera about it. Like, I teach a course, and this wasn't a plug for the course, but really, if you take the 2-day course, you're going to be able to treat probably 2/3 of oral facial pain very successfully. Just when you start to say, okay, this is what I'm looking for, this is the techniques, we'll show you a handful of, half a dozen techniques that you're going to get 50% of patients better with just those techniques. This is really an area that PT doesn't look at enough, in my opinion, but we really are the people that should be leading this. The literature and the American Academy of Oral Facial Pain, which I'm a member of, that's the sister academy, is, the conferences in Arizona was 500 attendees. It was like 75 PTs. So it's primarily dentists that are in this. And what the theme is most dentists are not treating this correctly. They're using outdated research. They're using outdated techniques. They're throwing an appliance in their mouth and saying, you should be fine. That would be like a PT walking, or a patient walking into your office and saying, I have back pain. You go, you know what? Put on this back brace. Problem solved. See you later. It's just not what the literature supports. You can really make a big dent in this if you're a PT looking to find your own way. If you're a clinic owner or practice owner looking to add a niche, this is an absolute home run. This is, if you go into your local orthopedic doctor's office, you're probably the 5th PT that stopped in that week. You go into your local dentist's office, you're the first PT that stopped in that office ever. So there's a huge area to do this. It's beneficial both from a patient care standpoint, which is why we all got into this, but it's also beneficial from a personal growth development and a business growth development as well. So I would really encourage anyone to reach out. I would be happy to be a mentor. Just shoot me questions. Hey, what do you think about this? I'm happy to guide anybody. The biggest problem with oral facial physical therapists is that there's not enough of us.
Well, thank you, Ryan. And just to clarify, what was that course you said? It was a 2-day course. What was the name of that course again?
It's 2 days. It's if you're going to look it up, and like I said, we'll shoot the email. We'll get it out in the thing. It's LPT seminars. So my clinic is, as you can see on the bottom, is Lynch Physical Therapy. So it's the abbreviation of that, lptseminars.com, and it'll give you all the information. And like I said, we're happy to come in and teach everyone in your organization, or we can set it up local. However, the idea is really just to get it out. And, in the website, it says demystify the treatment of TMD, because it really can be demystified over a weekend.
And so if this does happen to be passed along to a dentist or ENT's office, do you also provide seminars to them?
I do. So I'm in Maryland, and I give a lecture that is credentialed for 2 CE units for any of the dentists in Maryland. I would for anybody outside of Maryland, I'm happy to do it, but they don't get CEUs unless their study club or whoever organizes it that way. A lot of study clubs are set up that they can just, easily go to their dental board and petition, because it's already applied in Maryland. So it usually just sneaks right through with no problems. But for sure, I have a 2-hour lecture that I give to dentists, local all the time in their study clubs and everything, and they get CEUs for it. They kind of understand what we're doing, and hopefully get a new appreciation for PT and a new perspective of what they can look at for treating these patients. Because most dentists are trying to really help patients, but they don't know enough. So they're happy if they have a resource. Hey, let me get this out. I know that these people are going to take care of you. It's been a very good collaborative effort. You can get dentists on the phone. Dentists are happy to reach out. I talked to a dentist today when I was driving home today. It's much easier than get a primary care and ortho on the phone. I'll tell you that for sure.
Sure. Well, excellent, Ryan. I really appreciate your time. Thanks for jumping on and taking an hour and a half of your evening, because we know you're East Coast time. But again, anyone interested, please reach out to Ryan. And thanks for listening, everyone. Take care.
Thanks for having me.